I want to welcome everybody to the breast cancer webinar and introduce you to our speaker today. Shay Wunsch is a consultant for Haugen Consulting Group, and she brings experience in physician auditing, billing, coding, and compliance. She lives in a family farm in South Central Kansas and just welcomed her second baby girl, Clementine Rose. I'm sure you will enjoy her presentation today, so let's get started.
Great, thanks so much, Michelle. I'm happy to be here. Today we're going to talk about breast cancer since October is Breast Cancer Awareness Month. So we're just going to do some of the basics for ICD-10 and CPT coding today related to breast cancer. So we will start with some anatomy and terminology, as it does become important to know when we're coding for breast cancer, both ICD-10 and CPT coding, and then we'll talk about billing and AR issues as we go. So some facts about breast cancer. It's the most commonly diagnosed cancer in women, with 1 in 8 women in the United States will be diagnosed with breast cancer. Second leading cause of cancer death among women. And we do have 3.3 million breast cancer survivors in the United States alive today. And just a quick note that men can be diagnosed with breast cancer too, although it is rare. The good news is that in recent years, due to the decline in prescriptive hormone replacement therapy after menopause, we have seen a gradual reduction in female breast cancer incidence rates among aged 50 and older. The death rates from breast cancer have been declining since 1990, and in part that's going to be due to the early detection, all the screening, awareness, and the continually improving treatments that we get today. So what is neoplastic disease? Cancer describes a disease with abnormal cellular growth or neoplasia that often invades surrounding tissues or spreads to other sites. So if we look at the word neoplasm and break it apart, we have neo, which means new, and plasm, which means growth or formation. So neoplasms are often called tumors or masses, and they can be either solid or fluid filled. Cancer and malignant neoplasm are often used interchangeably, but neoplasm is not synonymous with cancer. So neoplasm can either be cancerous, like a malignant neoplasm, or non-cancerous, such as a benign neoplasm. So let's look at our breast anatomy. A healthy female breast is made up of 12 to 20 sections or glands, and those are called lobes. Each of these lobes is made up of many smaller lobules. So you can see a lobule there labeled on the picture. And this is the gland where milk is produced in women who are breastfeeding. Both the lobes and the lobules are connected by milk ducts. So you can also see ducts labeled on the picture. And those act as stems or tubes that carry milk to the nipple. The breast and the underarm also contain lymph nodes and vessels that carry lymph fluid and white blood cells, which are part of the immune system. And then much of the rest of the breast is fatty adipose tissue, and that tissue extends from the collarbone down to the underarm and across the middle of the rib cage. So I mentioned the lymph vessels earlier, but within that adipose tissue is a network of ligaments, fibrous connective tissues, nerves, lymph vessels, lymph nodes, and blood vessels. The lymph system is part of the immune system, and that's a network of lymph vessels and lymph nodes running throughout the entire body. Similar to how the circulatory distributes elements throughout the body, the lymph system transports disease-fighting cells and fluids. So you can see clusters of bean-shaped lymph nodes, and they're in fixed areas throughout the lymph system. They act as filters by carrying abnormal cells away from healthy tissue. So this is the top half of the lymph system, and you can see the clusters right around the breast, and those often come into play when we talk about breast cancers. And again, those are carrying abnormal cells away from healthy tissues. They act as filters. Generally, the lymph nodes in the axillary area, and that's kind of going to be the underarm or armpit area, those are going to be the ones linked to breast cancer coding. The type of breast cancer can be determined by the origin of the growth of the cancer cells, which is almost always in the lobes, lobules, or ducts of the breast. But when the cancer is found in nearby lymph nodes, it helps doctors identify just how far the cancer has spread. So the spreading process is known as metastasis. If the nearest nodes contain cancer, they usually take additional nodes to examine them for the presence or absence of cancer cells, and that helps them understand how far the disease has progressed. How does cancer start in the breast? Just like any other part of the body, the breast consists of billions of cells with specific function. The cells usually multiply in an orderly fashion where new cells continue to divide and replace the ones that have died. Sometimes the cells do develop abnormalities or mutation, and this occurs when the genes that usually check the cells that are replicating correctly fail to detect mutations. So when this happens, instead of the abnormal cells dying, they continue to divide and multiply, and sometimes they grow quite rapidly. So you can see in the middle of this picture, that cell in the very middle is mutated, or it's different from the rest of the cells there. So a tumor is a mass of abnormal tissue. There's really two types of breast cancer tumors, either non-cancerous or benign ones, and those that are cancerous, which are malignant. So when a tumor is diagnosed as benign, it can sometimes be left alone, or it can be removed if it's causing pain, depending on what the doctor thinks. But the malignant tumors are the cancerous tumors, and they can be aggressive and invade and damage surrounding tissue. So when a tumor is suspected to be malignant, the doctor will perform a biopsy generally first, and that determines the severity or aggressiveness of the tumor. And then metastatic cancer is when the cancer cells of the malignant tumor spread to other parts of the body. And that usually happens through the lymph system, and they can form a secondary tumor then. Breast cancer tumor grades, these are not to be confused with cancer stages, but the tumor grading system is used to classify a malignant breast cancer tumor based on the severity of the mutation and the likelihood it would spread. So the breast cancer cells are examined under a microscope, and what they look for is how closely the breast cancer cells resemble the healthy cells, and that's called the histologic grade. And they look for the shape and the size of the tumor cell's nuclei, and that's called the nuclear grade. And they also look at how rapidly those cells divide and multiply. So what tumor grades do is they help determine the best treatment plan. In general, a lower grade tumor means a better chance of full recovery, but nowadays there's many patients who make full recoveries at every stage, even with the highest grade of tumors. And these are the stages of breast cancer. So we have 5 stages starting with 0. Stage 0 means there's abnormal cells present, but they haven't spread to nearby tissue. 1 is the early stage where cancer has spread to other tissue in a small early area. 2 is localized, so that means the tumor is between 20 and 50 millimeters. Some lymph nodes are involved, or involved a larger tumor than 50 millimeters with no lymph nodes involved. And this is generally very effectively treated. 3 is a regional spread. So this is when the tumor is larger than 50 millimeters with more lymph nodes involved across a wider region. Some cases there's no tumor present at all, but cancer may have spread to skin or chest wall. And 4 is a distant spread, so cancer is spread beyond the breast to other parts of the body, such as the brain, the bones, lungs, and liver are common sites. And then we also have different types of breast cancer. So we have ductal carcinoma in situ. So that's the top left picture. That's a non-invasive cancer where abnormal cells have been found in the lining of the breast milk duct. The atypical cells have not spread outside of the ducts into the surrounding breast tissue. So that's what in situ means. It's just in that one area, hasn't spread. We also have lobular carcinoma in situ. This type of cancer does increase a person's risk of developing invasive cancer later on in life, but this is when the abnormal cells start growing in the lobules. And we have invasive ductal carcinoma. This is also known as infiltrating ductal carcinoma. It's the most common form of breast cancer. It represents about 80% of all breast cancer diagnoses. And this is when cancer that began growing in the duct has invaded the fatty tissue of the breast outside of the duct. We have invasive lobular breast cancer. It's a type of breast cancer that begins in the lobules, or those milk-producing glands, and the cells have broken out of the lobule. They begin to have the potential to spread to the lymph nodes and other areas of the body. There's also inflammatory breast cancer and Paget's disease of the breast. Those are both very rare forms of cancer. The Paget's disease involves the skin in the nipple and the areola. So those are the different types of breast cancer. And then we're going to move on to our ICD-10-CM coding. So in the classification, the Neoplasm classification in ICD-10-CM, you'll see different terms. So malignant primary is where the cancer starts. Malignant secondary is a metastasis, so the cancer has spread. Carcinoma in situ, it stayed in place where it began and has not spread. We have benign, which is not cancerous. Uncertain. Uncertain means that the tissue of the neoplasm has a well-defined histological appearance, but the behavior of malignant versus benign cannot be determined. So that's an actual, that is something a pathologist or someone who has looked at the cells would have to tell us, that it's uncertain, versus unspecified means that the behavior morphology is not documented. So don't confuse those two, as they are different codes. This picture is of breast tumor positions, and this is sometimes used in documentation to give us the location of the breast tumor, and it's using a clock on the breast to give us the location. So you can see 12 o'clock, 3, 6, 9, and then the 4 quadrants, so upper inner, lower outer, upper outer, and those are identified in the ICD-10-CM code. So just a handy picture in case you're seeing that in the documentation. And then we have many ICD-10-CM guidelines that help us code for cancer and specifically breast cancer as well. So we'll just run through some of the guidelines, the key guidelines. Sometimes we have primary malignant neoplasms that overlap 2 or more contiguous sites, and what that means is that the 2 sites are next to each other. Coding guideline 1.C.2, so this is chapter 2 guidelines, state that a primary malignant neoplasm with overlapping site boundaries should be classified to the subcategory 0.8 for overlapping lesion, unless the combination code is specifically indexed elsewhere. For multiple neoplasms of the same site that are not contiguous, such as tumors in different quadrants of the same breast, codes for each site should be assigned. So if you're looking at our picture here, we have 2 lesions on that breast and they're in different quadrants. So in that case, you would need a code for each site. And then we have coding guideline 1.C.2.I, and that states that the patient may have more than one malignant tumor in the same organ. The tumors may represent different primaries or metastatic disease. If the documentation is unclear, the provider should be queried regarding the status of each tumor to assign the correct codes. And this brings us to our first polling question. Michelle?
Okay, let me go ahead and get that launched. All right, so the question is, right breast tumor which spread contiguously over the upper inner quadrant and part of the upper outer quadrant in a female patient. Is the answer A, C50.211, malignant neoplasm upper inner quadrant of right female breast, B, C50.411, malignant neoplasm of upper outer quadrant of right female breast, C, C50.811, malignant neoplasm of overlapping sites of right female breast, or D, C50.211, C50.411. Go ahead and select your answer. We'll just give you a couple more minutes here as everyone's getting their answers submitted. Okay, it looks like we got most everybody, so I'm going to go ahead and close that polling question. And the correct answer is C, C50.811, malignant neoplasm of overlapping sites of right female breast.
Yeah, great job. It looks like the majority of you guys did get C for that answer. And that has to do with the guideline that we just talked about, that if the tumor is contiguous, you can use the 0.8 for overlapping sites of the right female breast. So great job, everybody. The next guideline we have is 1.C.2.A, and this is for if a patient comes in for treatment. So if the treatment is directed at the malignancy, you should designate the malignancy as the first listed diagnosis, and the only exception to this is if the patient encounter or admission is for the administration of chemo, immunotherapy, external beam radiation. You need to assign the Z51 category code as first listed, and then the cancer or other diagnosis being treated as a secondary diagnosis. And then 1.C.2.B tells us that when the patient is the encounter or admission for the primary malignancy with metastasis, and the treatment is directed toward the metastasis only, the metastasis site is the first listed diagnosis, even though the primary malignancy is still present. So an example of this, a patient diagnosed with primary breast cancer, but now comes in for biopsy of a metastatic lung tumor. So in that case, since the treatment on that day is for the lung tumor, you would sequence the lung tumor first, followed by the primary breast cancer. And then we have some more guidelines here. These are associated with anemia, which is a common complication that can occur either due to the malignancy or due to the treatment. So on our first box on top, we have anemia associated with malignancy. So this just says when the admission encounter is for the management of the anemia, and this is when the anemia is associated with the malignancy, and the treatment's only for the anemia, you still code the malignancy code first, followed by the appropriate anemia code. That's a little counterintuitive to me, but that's what the guideline says. And then the anemia associated with chemotherapy, immunotherapy, and radiation therapy, if the anemia is due to those treatment modalities, and then they're coming in for treatment of the anemia, you sequence the anemia first, and then followed by the neoplasm code and the adverse effect code. So there's adverse effects for chemo or immunotherapy, the T45 category, and then for the radiation therapy, it's that Y84.2 code. So the documentation is going to need to specify what the anemia is due to. And we also have guidelines for sequencing of neoplasm codes. So the first one is for malignant neoplasm and a pregnant patient. When a pregnant woman has a malignant neoplasm, code from subcategory 09A.1 is sequenced first, followed by the neoplasm code. Complication associated with the neoplasm. When the encounter is for the management of a complication associated with the neoplasm, so like dehydration, the treatment is only for the complication, then you code the complication coded first, followed by the neoplasm code. Complication from surgical procedure for treatment of a neoplasm. So when the encounter is for treatment of a complication resulting from a surgical procedure performed for the treatment of the neoplasm, you should designate the complication as the first listed. And pathological fracture due to neoplasm, this is going to depend on the circumstances of the admission or what the reason for the encounter was for. But when the encounter is for a fracture due to a neoplasm and the focus of the treatment is the fracture, the code from subcategory M84.5 is sequenced first, and then you follow that by a code for the neoplasm. If the focus of treatment is for the neoplasm and the patient just has an associated pathological fracture, then the neoplasm code is sequenced first, followed by the pathological fracture M84.5 code. And that brings us to our second pop quiz.
Okay, our second polling question. A patient presents with increased weakness with a history of right breast cancer, status post-mastectomy, and is now on chemotherapy and radiation. Diagnosis, anemia due to breast cancer. What is the correct answer? A, D63.0, C50.911, or B, C50.911, D63.0. Go ahead and select the correct answer. Got a few more out there trying to answer the question, and give you a few more minutes here, a couple seconds.
And the question got a little bit cut off, but the diagnosis was anemia due to breast cancer.
Okay, we're going to go ahead and close this polling question. And the correct answer is B.
Yep. And it looks like the majority of you just barely got the correct answer. So the correct answer is B, and it goes back to that coding guideline that we talked about, that when the patient has anemia due to cancer and the patient is presenting for, I'm just going to go back to the slide so we can all see it here. Oh, right here, this one. So it's this very top guideline. When the admission encounter is for management of anemia associated with the malignancy and the treatment is only for the anemia, the malignancy code is sequenced as the first listed code followed by the appropriate anemia code. So that's why the answer was B on that question. So great job, guys. The next guideline we're going to talk about has to do with personal history of malignant neoplasm. This happens a lot when documentation where we'll see history of cancer or just cancer as a final diagnosis. So sometimes you kind of have to look around, look back at all the documentation to determine whether it's a history of or a current malignancy code is correct. But the main point to keep in mind is whether the neoplasm is still undergoing treatment or not. So when a primary malignancy has been previously excised or eradicated from its site and there's no further treatment directed to that site and there's no evidence of any existing primary malignancy, that's when you can use a code from category Z85, personal history of malignant neoplasm. Any mention of extension, invasion, or metastasis to another site is coded as a secondary malignant neoplasm to that site. The secondary site may be the primary diagnosis code with the Z85 code used as a secondary code when the primary malignancy has been excised, but further treatment such as additional surgery, radiation therapy, or chemotherapy is directed to that site. The primary malignancy code should be assigned until the treatment is completed. So subcategory Z85.0 through Z85.7 should only be assigned for the former site of a primary malignancy, not the site of a secondary malignancy. Codes from subcategory Z85.8 may be assigned for the former site of either a primary or a secondary malignancy. They're both included in that subcategory. And that brings us to another polling question.
Okay, let me go ahead and get that one going. When would only a Z code for history of neoplasm be assigned? A, patient presenting follow-up mammogram with a history of breast cancer eradicated 4 years ago, or patient with a history of breast cancer, status post-mastectomy, now presenting for chemotherapy, or C, patient with a remote history of breast cancer, admitted with pain and found to have bone metastasis. Go ahead and select your answer. See if we can get a few more answers coming in. Okay, it looks like the majority of you have selected your answer. I'm going to go ahead and close this. And the correct answer is A, patient presenting for follow-up mammogram with a history of breast cancer eradicated 4 years ago.
Yeah, great job, guys. It looks like the majority of you did get that correct. And that's the only answer where only a Z code for history of neoplasm would be assigned, and it would just help explain why that patient is getting that follow-up mammogram done. So next we have category Z51 for chemo, immunotherapy, and radiation therapy. And that category is called Encounter for Other Aftercare in Medical Care. I kind of mentioned this code previously a little bit, but this code is used when the patient is admitted solely for anti-neoplastic treatment. You're going to code the Z51 first. You can code the malignancy second, and you can code more than one Z51 code depending on what all is being done during that visit or during that admission. If the patient is admitted for radiation, chemo, or immunotherapy, and during that visit the patient develops complication, you still code the Z51 first and then the complication second. If the patient's coming in for surgical removal of a neoplasm and then they're following it with chemo or radiation therapy, you're going to code the neoplasm first. And that brings us to another pop quiz. So I hope you guys are paying attention.
Okay. When would the primary diagnosis be a Z code for encounters involving neoplastic therapy? Is it A, patient presented for double mastectomy followed by initiation of chemotherapy? B, patient presented with increased weakness and fatigue and was found to have anemia due to chemotherapy? Or C, patient was admitted for chemo for bone metastasis and during admission developed dehydration? Go ahead and select your answer. Okay, it looks like the majority have selected. I'm going to go ahead and close this poll. And the correct answer is C, patient was admitted for chemotherapy for bone metastasis and during admission developed dehydration.
Yeah, and it looks like everybody got that one correct. So great job, guys. And that was correct because that admission was for the chemo and that corresponds with that Z51 code. So great job. The next part of the ICD-10 codes I wanted to mention was for screening. Screening tests are going to be vital for early detection, prevention, and treatment of malignant conditions. We have a screening of breast malignancy codes. Those fall under category Z12.3, and we are reminded under category Z12 to use an additional code from category Z80 to identify any family history of malignancy. Some of the advancements in technology and screening include the 3D or tomosynthesis. You might see that noted as TOMO. It's the same technology as regular 2D mammograms. The 2D only takes images from the front and side, and the 3D provides images of the breast in slices from many different angles. If a condition is discovered during a screening, the code for the condition may be assigned as an additional diagnosis. If the test is performed because the patient has some sign or symptom of a suspected condition, that would make this a diagnostic exam, so the screening codes would not apply in that scenario. We also have some aftercare, an aftercare code, and this falls under guideline 1.C.2.0. And this is for aftercare following surgery for a neoplasm. It's really assigned for routine visits that are a normal part of the continued care during the healing or recovery phase after the acute phase of treatment is completed. They are also used when treatment of a sequela is required. Do not assign if the patient is receiving treatment or for current acute disease. And we have follow-up care guideline, and that's 1.C.2.P. This has to do with codes Z08 and Z09. They're used to explain continued surveillance once all treatment has been completed. Follow-up insinuates that the condition no longer exists, and it can be used in conjunction with those history codes that we just talked about. And this brings us to our last pop quiz.
Okay, which of the circumstances would a follow-up code be used? A, screening mammogram due to a family history of breast cancer. B, surveillance mammogram following removal of malignant tumor from breast 4 years ago. Or C, admission of a patient with pain found to be due to metastasis from a remote history of breast cancer. I'll give you a few moments to select your answer. Okay, I think we got the majority of the answers. I'm going to go ahead and close that. And the correct answer is B, surveillance mammogram following removal of malignant tumor from breast 4 years ago.
Yeah, and it looks like you guys did a great job answering that question, and that is the appropriate circumstance for a follow-up code, just explaining why that surveillance mammogram is being performed. And just a couple more slides on ICD-10. We have some codes for prophylactic organ removal. This is becoming a little bit more common now that we have the BRCA tests and things like that. So these are for when a patient is the encounter specifically to have a currently healthy organ removed in order to prevent future malignancy. The appropriate Z40 code should be assigned as the principal or first listed diagnosis. If the patient currently has a malignant tumor in another site, that malignancy should be coded in addition. So an example would be a prophylactic removal of breast due to an established susceptibility to cancer. And another reason for a prophylactic surgery might be to prevent a new primary malignancy when a previous malignancy in another site has been already diagnosed. The use additional code note just tells us to add codes to identify risk factors when applicable. And one last slide on ICD-10-CM. The mass or lump codes were new. These codes were new in 2018. So we see those in the same manner as we see the breast cancer designation codes in the same location. So you'll see on this slide just a few examples of the upper outer quadrant, upper inner quadrant, and that's for mass or lump. And this also includes the term nodule as well. So we're going to move on to CPT now, and we'll start with kind of at the beginning what happened with the breast cancer diagnosis, starting with some of the diagnostics that might be done. So in ultrasound, we have breast ultrasound codes. We have a complete and a limited. The complete 76641 is for all 4 quadrants of the breast and the retroareolar region. And 76642 is just limited to 1 or more elements. So if you're coding the complete, you'll want to make sure all of those elements are included in the documentation. And the modifier 50 does apply if these are done bilateral. And if it's only an axillary ultrasound, CPT does instruct us to use 76882. For mammography, the screening mammography codes are here. These are different from the diagnostic mammography codes, but we have 77067, and then we have an add-on code if TOMO is done, so 77063. The code description for 77067 includes CAD, and CAD stands for Computer Aided Detection. What that is just a computer program that highlights areas of a mammogram that may be abnormal, so the radiologist can go in and decide if those areas really are abnormal or not. This is a covered, screening mammography is a covered Medicare service, and they do accept these CPT codes now. You can look up NCD 220.4 for more information. And then we also have that screening mammography ICD-10 code that we talked about as well that corresponds with the CPT codes. And then we have diagnostic mammography. These are divided based on whether it's done unilaterally or bilaterally. So those are the code description differences there. And then we also have code for digital breast tomosynthesis, and that's going to be that 3D again. And that's divided unilateral and bilateral as well. Some other breast radiology that you might see. First, we have on the right side of the screen, you see 77053 for mammary ductogram. So 77053 ductogram or galactogram, that's for a single duct, and it's the supervision and interpretation part of that procedure. And 77054 is for multiple ducts, and again, that's the supervision and interpretation. This is an injection procedure where a needle or a cannula is inserted into the duct of the breast, and then they insert contrast for visualization. So those codes both have a technical and professional component, and the surgical portion of that procedure is reported with 19030. For the MRI, there's two MRI codes, unilateral or bilateral, and those are with or without contrast. And then there's also a code for that computer-aided detection with the breast MRI, and that's a Category 3 code, 0159T. And that's just used to evaluate lesions in the breast at a very specific level. And it's performed secondary to that primary MRI procedure. So those are the radiology procedures. Next, we have biopsy procedures. FNA is a quick and simple procedure that removes some fluid or cells from a breast lesion or cyst with a fine needle. The sample of the cells is smeared on a glass slide and sent to pathology, and then the results can determine the nature or the diagnosis of the lesion. Excisional breast surgery does contain some biopsy procedures, so the 19100 and 19101. The 19100 is a percutaneous or a needle biopsy, and then the 19101 is an open or incisional biopsy. They both involve removal of differing amounts of tissue for diagnosis. So those are both without image guidance. There are various types of imaging guidance that are used for breast procedures. Stereotactic is special mammography machine using x-rays to help guide the provider's instrument to the site of abnormal growth. We have ultrasound, which is shown in the picture there. That's high frequency sound waves creating an image to use needle placement. And we have magnetic resonance, and that's the use of powerful magnetic fields and radio frequency pulses to create detailed images. These codes 19081 through 19086 are for breast biopsy with placement of breast localization devices. So an example would be a clip, a metallic pellet, and these do include imaging of the biopsy specimen when performed, and this is done percutaneously. So the first lesion you'll see, and then the type of guidance, the second lesion, or each additional lesions are with the add-on codes. So these codes differ by the type of image guidance that's used. So here's the steps for coding breast biopsies. First, we're going to confirm the type of guidance used, if any. You'll determine the type of biopsy. Is it percutaneous or is it open? You'll count the number of lesions that were biopsied, and then you'll need to determine if it's unilateral or a bilateral procedure, whether modifier 50 applies. There are some CPT guidelines for coding breast biopsies. So when more than one breast biopsy is performed using the same imaging modality, use an add-on code whether the additional service is on the same or contralateral breast. So whether it's on the same or opposite side, you're going to use the same add-on code. If additional biopsies are performed using different imaging modalities, report another primary code for each additional modality. So hopefully that makes sense. And and it is a CPT guideline, so it's in your book. The next step a breast cancer patient might undergo is excision. So after the mass has been located, the patient will likely go under an excision, so where a surgeon creates an incision and excises the mass or lesion and some of the surrounding tissue, and then the wound would be sutured and bandaged. 19120 is reported per incision, not per mass removed. And this is used only when the mass is removed with little or no margin. 19301 is reported when the procedure describes open incision of breast tissue and includes specific attention to adequate surgical margins surrounding the breast mass or lesion. So in that one, they're removing a little bit more tissue. Sometimes the surgeon may excise breast mass like 19120, and then the pathology reveals a malignancy and the patient has to go back to the OR to remove additional tissue. You can bill the follow-up excision with 19301 and use modifier 58 to indicate it was stage or related procedure during the post-op period, because these do have 90-day global periods. So you're going to need to have good documentation in order to tell the difference between these codes and make sure you're billing the correct CPT code. Another type of excision or procedure a breast cancer patient might undergo is partial mastectomy. So the first code 19301 was the one we just talked about, but it's also called a lumpectomy, and it involves removal of the tumor along with adequate amount of normal breast tissue around the tumor, skin, and lining of the chest muscle. If the procedure is performed without axillary lymphadenectomy, then that's when you report the 19301. If the axillary lymph nodes are removed along with the tumor, adequate normal breast tissue around the tumor, skin, and lining of the chest wall, then you're going to report the 19302. So 19302 is only reportable when a complete axillary dissection is performed. You don't report 19302 for removal of just a few nodes. Code 19302 does involve removal of lymph nodes between the pectoralis major and pectoralis minor muscles and axillary lymph nodes. So all identified lymph nodes are removed in the 19302. Mastectomy procedures are unilateral, so you'll have to add modifier 50 to report bilateral procedures. These next mastectomy procedures are a little bit more complex. So a skin sparing or nipple sparing mastectomy is reported with code 19303, regardless of the amount of skin removed or whether the nipple is preserved. And the subcutaneous mastectomy is typically used to treat patients with severe symptomatic fibrocystic change or patients who are undergoing breast cosmetic procedures in which significant tissue is removed to achieve symmetry. So 19304 is a little bit more complex. And then moving on, and the next step would be radical mastectomy. So there is 3 codes in this category: 19305, 306, and 307. A radical mastectomy, as the name suggests, radically removes more than just the diseased tissue. This procedure can be performed in the following 2 ways. They can remove the entire breast tissue, axillary lymph nodes, pectoral muscle, and surrounding fatty tissue, and that would be 19305. That includes the pectoral muscle and the axillary lymph nodes. 19306 is performed when the cancer invades the chest wall. This type of mastectomy is really rarely performed these days, but it does include removal of entire breast tissue, skin, axillary lymph nodes, internal mammary nodes, and pectoral muscles. It's also called an urban operation. More commonly, they're doing the modified radical mastectomy. It's less extensive and it's, like I said, more commonly performed, but it does involve the removal of the entire breast tissue, so the skin, areola, nipple, and the axillary lymph nodes. The pectoralis minor muscle may or may not be removed. However, the pectoralis major muscle is not removed. You can report 19307 for modified radical mastectomy, including axillary lymph nodes with or without pectoralis minor muscle, but again, it excludes the pectoralis major muscle. And modifier 50 does apply to these codes. These are unilateral procedures. After or during the excision procedure or mastectomy procedures, the reconstruction codes may apply. So for 19340, this is when for a patient that can or wants to opt for immediate insertion of a full-size saline or silicone-filled prosthesis at the time of mastectomy, and this does attain a speedy reconstruction. So other times, the surgeon closes the surgical site after mastectomy to allow the chest to heal, and then patients can choose to have the reconstruction done later. This is often done when radiation is going to be done because radiation can damage the reconstructive breast. So the delayed insertion is 19342. 19357 is an increasingly common method of breast reconstruction surgery, and what that involves is the implantation of a tissue expander during the mastectomy procedure. And then after reviewing the path report, the surgical team decides no radiation therapy is needed, then the implant can be placed immediately in the site of the expander. If the patient does have to do radiation, the expander preserves space for a future implant once radiation therapy is completed. Just keep in mind that unlike 19340 and 19342, with the 19357, you use the same code whether procedure is immediate or delayed after the mastectomy. And since including subsequent expansion is included in that 19357's description, you can't bill separately if the patient returns periodically for gradual expansion, which is performed to stretch the overlying tissue to a size suitable for implant insertion. And here's an example of the 19357. Like I said, this is becoming increasingly common. It is a 90-day global day procedure, and it does include all of these components. So quite a few. One notable thing is it does include excision of dog ears, and that can be extensive, especially in very large breasts. It is included in the global. There is an exception though when the dog ear excisions require extension of the incision for some distance in both directions. If the extensive dissection and prolonged operative time is required, you can use modifier 22, but just make sure it's appropriate and that documentation really shows that extra work allowed for modifier 22. So after a patient's mastectomy, a reconstructive surgeon will evaluate the skin flaps and prepare to insert the tissue expander. Following placement of the expander, the patient will present for subsequent fills of saline until the breast has expanded to the patient's liking. 19357 has 90 global days. So all office visits for progressive expansion during this time is included, and then any visits beyond that can be coded with E&M visits. If they're using alloderm or a dermal matrix, it is additionally billable with add-on code 15777. It's only to be used for biologic implants such as acellular dermal matrix for soft tissue reinforcement. If a non-biologic mesh is used, you can report it with an unlisted code 19499. And if you're reporting the alloderm, depending on your setting and if you can report it, the code for that is Q4116. So here's some examples on how this might look, some different scenarios with the 19357 code. So for a tissue expander breast reconstruction with biological implant, you would use 19357 with the 15777. If it's a bilateral procedure, you'll add modifier 50. If they're using non-biological mesh, you can add that unlisted code 19499 to the 19357. And then if they're doing it with a flap procedure, such as a Ryan flap, that can be coded with 14001 in addition to the 19357. So sometimes, or when you get to the point for general exchange of tissue expander for permanent prosthesis, that can be reported with 11970. 11970 includes minor adjustments to the capsule. Sometimes significant adjustments are made to the capsule, many of which comprise a significant part of the procedure. So you can report with 19342. So for example, sometimes the capsule must be significantly modified for the inframammary crease, be lowered or raised, or partial or total capsulectomy must be performed. And that would be and another example is for breast reconstruction with expander in a patient undergoing postoperative expansion. When the tissue expander is replaced, it may be that the capsule is found to be very tight and multiple radial incision may be required in the capsule to accommodate the permanent prosthesis and form a symmetrical contour to the opposite breast. So those are codes used for the exchange of the tissue expander. And here is a case scenario. So you can see in this case, they came down on the expander, they peeled it free and removed it, washed the pocket, and then put the implant in. So that would be 11970. And then here's another case for 19342. So that code is for the delayed insertion of breast prosthesis following mastopexy, mastectomy, or in reconstruction. So in this case, the capsule was found to be very tight and thick, so multiple radical incisions were made and a complete capsulectomy was performed. So that would be 19342. Any revisions done at this time to properly shape the breast are included in the expander exchange. Because the breast is not fully reconstructed until after all stages are complete, 19380 may be reported only when correcting later contour irregularities or deformities. So if you're billing 19380 at the time of the exchange, it's just like filing a claim for something that's still in process of being done. And then the last part is for nipple reconstruction. Nipple is reconstructed in the final stage. Any nipple areolar reconstruction, such as a skate flap, CV flap, cartilage graft, can be reported with 19350. The graft or flap is included in the 19350 and can't be billed separately. Nipple tattooing, which can be done as an office procedure, is also included in the 19350. If no other reconstruction has been done on the nipple, or if you're just performing touch-ups, they can bill the tattooing separately. So example would be the patient presents to her surgeon's office 3 years after her breast reconstruction. She previously had bilateral skate flap nipple reconstruction with tattooing, but the tattoos have faded and the patient desires a touch-up. Each nipple is approximately 20 square centimeters, equaling a total of 40 for both nipples. So in that case, we would go ahead and bill 11921 and 11922. And a quick note for AR issues. So 19357 with 15777, and that would represent the breast reconstruction with biological implant. Many payers will reimburse for both of these codes when they're billed together. Sometimes surgeons are always using biologic implant, so 15777 with the 19357, and they're receiving denials as stating that this is routine. So they're bundling these. This is probably a code pair to watch for to be bundled in the future, since we know that Medicare does and other payers analyze which codes are often being billed together, and if they're always being billed together, then likely they can get bundled at some point. And for our references today, the statistics were from the nationalbreastcancer.org website, and we use CPT 2018 and ICD-10 2019. And that is the end of the presentation for breast cancer. I do see a couple of questions, so I'll try to answer here. We have one, can we code for injection of radioactive tracer and blue dye for sentinel lymph node biopsy? So if the injection and the radioactive tracer is performed preoperatively, then you can report that. So 38792 code. The blue dye is going to be included in the 38900 code for the sentinel lymph node biopsy. And then let me see. If a patient has a new breast cancer that already spread to lymph nodes, would you code a contiguous code or metastatic to lymph nodes? I would code a metastatic to lymph node in that case. And then, oh, I think that's it. Yep, I think that's it, Michelle.
You got all the questions. Yes,
Okay.
Thank you, Shay.
Yeah.
Thank you. Thank you all for joining us today. If you enjoyed today's presentation, please join us for any of our upcoming webinars. Our next one is October 18th. It's our Hocus Pocus, Air Goes In, Air Comes Out, How Hard Can It Be? Where we will discuss common respiratory ailments with our presenter, Christy Pollard. Again, thank you all for joining us. The link to the recording will be sent out in a follow-up email within 48 hours. Don't forget to take a moment to fill out the survey, and please enjoy the rest of your day. Thank you all. Bye-bye.